Are you taking medication every single day that's secretly destroying your erections, and your doctor never told you about the side effects? Hello, gentlemen. I'm Dr. Mika Hayashi, a urologist with over a decade of experience helping men over 50 reclaim their sexual function. Today, I'm revealing the 5 most common medications that cause erectile dysfunction and reduced libido, backed by the latest clinical research and pharmacological data. Studies indicate that approximately 25% of all erectile dysfunction cases are directly caused by medications. That's 1 in 4 men. Analysis of Vigibase, the World Health Organization's global pharmacovigilance database, containing millions of adverse event reports, identified specific medications with the highest reported frequency of sexual side effects. Here's what makes this so devastating. Most doctors never warn you about these sexual side effects when writing the prescription. You start taking the medication, your erections weaken or disappear, and you assume it's just aging or stress. You never connect it to the pill you take every morning. Before we dive in, hit that like button right now. Comment below where you're watching from, and subscribe so you never miss critical health information for men over 50. Now, let me reveal which 5 medications are most likely destroying your sex life, the exact mechanisms causing the damage, and what you can do about it. Before I reveal the 5 medications, you need to understand the disturbing psychology behind why this problem is so widespread. Most doctors simply don't discuss sexual side effects when prescribing medications. They focus on the primary therapeutic benefit, whether that's lowering blood pressure, treating depression, or managing pain, without adequately discussing how the medication might affect your sex life. But here's the shocking part. Research reveals a phenomenon called the nocebo effect in reverse. In one landmark study, patients who were told about potential sexual side effects before starting a medication reported erectile dysfunction at much higher rates than patients who weren't warned. Among those informed about sexual risks, almost 1/3 reported erectile dysfunction. Among those not informed, only 3% reported it. This creates a perverse incentive. Some doctors deliberately avoid mentioning sexual side effects, believing that if they don't tell you, you won't experience them. This is medically and ethically questionable, leaving men confused and suffering when problems develop. Additionally, many men feel too embarrassed to report sexual problems to their doctors. Studies show that sexual dysfunction is significantly underreported. You suffer in silence, assuming nothing can be done, when in reality, simple medication adjustments could solve the problem completely. One patient, 62 years old, had been taking an SSRI antidepressant for 3 years. His erectile function had progressively declined to the point where he could barely maintain any erection. He never connected it to his medication because his doctor never mentioned sexual side effects. After I identified the medication as the culprit and worked with his psychiatrist to switch to bupropion, his erectile function returned within 4 weeks. Understanding which medications cause problems and the exact biological mechanisms is the first step toward fixing them. If this resonates with you, hit that like button and drop a comment. Medication number 1. Antidepressants, especially SSRIs. The first and most common medication class causing sexual problems is antidepressants, particularly selective serotonin reuptake inhibitors, or SSRIs. SSRIs include fluoxetine, which is Prozac, sertraline, which is Zoloft, paroxetine, which is Paxil, citalopram, which is Celexa, escitalopram, which is Lexapro, and fluvoxamine, which is Luvox. Research shows that 30% to 50% or more of patients on SSRIs report sexual dysfunction, with some studies showing rates as high as 58% to 73%. A multi-center prospective study found that citalopram had the highest incidence at 72.7%, followed by fluvoxamine at 62.3%, and fluoxetine at 57.7%. Here are the exact biological mechanisms causing sexual dysfunction. Mechanism 1. Increased serotonin affecting specific receptors. SSRIs increase serotonin levels by blocking its reuptake. While this helps treat depression, serotonin also inhibits sexual responses. Specifically, agonism of 5-HT2 and 5-HT3 receptors inhibits erections and delays ejaculation. Postsynaptic antagonism of 5-HT2 receptors stimulates sexual behavior, so SSRI agonism of these receptors is thought to be responsible for sexual dysfunction. Animal studies show that 5-HT2C agonists specifically inhibit ejaculation. Mechanism 2. Decreased dopamine activity. Increased serotonin inhibits dopamine, the neurotransmitter critical for sexual drive and arousal. Without adequate dopamine signaling, libido disappears. Mechanism 3. Blockade of cholinergic and alpha-1 adrenergic receptors. SSRIs affect these receptors, resulting in direct inhibition of both sympathetic and parasympathetic sexual functioning, the nervous system pathways controlling erections. Mechanism 4. Inhibition of nitric oxide synthetase. SSRIs decrease the availability of nitric oxide, the molecule that signals blood vessels in your pennies to relax and dilate. Without nitric oxide, erections are impossible. Mechanism 5. Elevation of prolactin levels. SSRIs can increase prolactin, which suppresses testosterone production and directly reduces libido and erectile function. The sexual side effects include difficulty achieving or maintaining erections, reduced sexual desire or libido, delayed ejaculation or complete inability to ejaculate, reduced intensity of orgasm or anhedonic orgasm, where orgasm occurs without pleasure, and genital numbness or reduced sensation. Concerningly, some patients develop post-SSRI sexual dysfunction, or PSSD, where sexual problems persist even after stopping the medication. While relatively rare, this condition can be permanent and currently has no known treatment. What you can do about it? First, never stop taking an antidepressant without consulting your doctor. Stopping suddenly can cause serious withdrawal symptoms and worsen depression. Second, talk to your prescribing doctor about the sexual side effects you're experiencing. Be specific and honest. Third, ask about alternatives. Bupropion, which is Wellbutrin, is significantly less likely to cause sexual problems because it works on dopamine and norepinephrine, not serotonin. It's sometimes even prescribed to counteract sexual side effects from other antidepressants. Mirtazapine, which is Remeron, may also avoid sexual dysfunction. Newer antidepressants like vilazodone and vortioxetine have additional serotonergic mechanisms beyond simple reuptake inhibition, and clinical trials suggest they may have lower rates of sexual side effects compared to traditional SSRIs. Fourth, within the SSRI class, fluoxetine has a lower affinity for certain receptors, particularly 5-HT2C receptors, that are implicated in sexual dysfunction. Some patients experience improvement by switching from one SSRI to fluoxetine specifically. Fifth, augmentation strategies can help. Adding bupropion 75 to 150 milligrams daily to your existing SSRI can sometimes reverse sexual dysfunction without requiring you to stop the SSRI that's working for your depression. Sildenafil, which is Viagra, has been shown in systematic reviews to improve erectile dysfunction in men taking SSRIs. One patient switched from sertraline to bupropion under his psychiatrist's guidance. Within 6 weeks, his depression remained well controlled, but his erectile function and libido returned almost completely. He told me, "I wish I'd known years ago that not all antidepressants cause these problems. I suffered unnecessarily for 3 years." SSRIs are life-saving medications for many men, but the sexual side effects are real, severe, and often reversible with medication adjustments. Comment below. Are you taking an SSRI? Let me know. Medication number 2. Blood pressure medications, especially thiazide diuretics. The second major medication class is blood pressure medications, particularly thiazide diuretics and beta blockers. Thiazide diuretics include hydrochlorothiazide, which is HCTZ or microzide, chlorthalidone, which is Hygraton, and indapamide, which is Losol. Research specifically identifies thiazides as the most common cause of erectile dysfunction among all high blood pressure medicines. Beta blockers also commonly cause sexual problems. These include metoprolol, which is Lopressor, atenolol, which is Tenormin, propranolol, which is Inderal, and carvedilol, which is Coreg. Here are the exact biological mechanisms. Mechanism 1. Reduced blood flow to the penis. Thiazide diuretics decrease overall blood volume by increasing urination. Lower blood volume means lower blood pressure, which is the therapeutic goal. But it also means reduced blood flow to your penis, making erections weaker or impossible. Mechanism 2. Reduced zinc levels. Thiazides increase urinary zinc excretion. Zinc is critical for testosterone production and prostate health. Chronic thiazide use can lead to zinc deficiency, which suppresses testosterone synthesis and directly impairs erectile function. Mechanism 3. Interference with sympathetic nervous system. Beta blockers interfere with the sympathetic nervous system signals that help initiate erections. They block beta-adrenergic receptors, which are involved in the cascade of events leading to penile smooth muscle relaxation and arterial dilation. Mechanism 4. Increased fatigue and reduced exercise tolerance. Beta blockers reduce heart rate and cardiac output, leading to fatigue. This indirectly reduces libido and interest in sex because you simply don't have the energy. The sexual side effects include difficulty achieving erections, difficulty maintaining erections even if initially achieved, reduced libido and sexual interest, fatigue that reduces interest in sex, and in some cases, retrograde ejaculation where semen goes into the bladder instead of out through the penis. What you can do about it? Again, never stop blood pressure medications without consulting your doctor. Uncontrolled high blood pressure is far more dangerous than erectile dysfunction and can itself cause permanent vascular damage, including to the arteries feeding your penis. Talk to your doctor about alternative medications. ACE inhibitors like lisinopril, enalapril, and ramipril, and angiotensin receptor blockers, or ARBs, like losartan, valsartan, and telmisartan, generally have much lower rates of sexual side effects compared to thiazides and beta blockers. These medications work by different mechanisms that don't reduce blood volume or interfere with the nervous system signals necessary for erections. Calcium channel blockers like amlodipine and diltiazem also tend to have fewer sexual side effects and are effective alternatives for many men. Your doctor can often switch you to an equally effective blood pressure medication with far fewer sexual impacts. The key is asking specifically about sexual side effects when discussing alternatives. One patient had been on hydrochlorothiazide for 8 years with progressive erectile decline. He assumed erectile problems were just part of having high blood pressure. His cardiologist switched him to lisinopril, an ACE inhibitor. Within 5 weeks, his blood pressure remained perfectly controlled at 125/78, but his erectile function improved dramatically. He went from barely achieving partial erections to maintaining firm erections throughout intimacy. He said, "Nobody told me the medication itself was the problem. I wasted years assuming this was permanent." Blood pressure control is critical for long-term health, but it doesn't have to come at the cost of your sex life. Different medication classes achieve the same blood pressure goals with dramatically different sexual side effect profiles. Medication number 3. Opioid pain medications. The third medication class is opioid pain medications, and the mechanism here is particularly insidious because it directly suppresses your body's natural testosterone production. These include oxycodone, which is OxyContin, hydrocodone, which is Vicodin, morphine, fentanyl, codeine, and tramadol. Additionally, medications like gabapentin, which is Neurontin, and pregabalin, which is Lyrica, while technically anticonvulsants, are often prescribed for chronic pain and also show high rates of reported erectile dysfunction in pharmacovigilance databases. Here is the exact biological mechanism. Opioids disrupt the hypothalamic pituitary gonadal axis, the hormonal feedback system that regulates testosterone production. Opioids bind to mu-opioid receptors in the hypothalamus, causing negative feedback. This leads to decreased production of gonadotropin-releasing hormone, or GnRH. Without adequate GnRH, your pituitary gland doesn't release luteinizing hormone, or LH, and follicle-stimulating hormone, or FSH. Without LH, your testes don't produce testosterone. This condition is called opioid-induced hypogonadism, or secondary hypogonadism. Long-term opioid use can lower testosterone levels by 50% or more in some men. Studies show that men on chronic opioid therapy have testosterone levels averaging 200 to 300 nanograms per deciliter, well below the normal range of 300 to 1,000 nanograms per deciliter. Lower testosterone directly causes reduced libido, erectile dysfunction, loss of muscle mass, increased body fat, fatigue, depression, and cognitive impairment. Additionally, opioids cause sedation and mental clouding, which indirectly reduces sexual interest and arousal. What you can do about it. If you're taking opioids for chronic pain, talk to your doctor about pain management alternatives. Modern pain management recognizes that long-term opioid use often causes more problems than it solves. Alternatives include non-opioid pain medications like NSAIDs, such as ibuprofen or naproxen, or newer options like celecoxib, physical therapy and rehabilitation to address the underlying cause of pain rather than masking symptoms, nerve blocks or epidural injections for localized pain, non-medication approaches like acupuncture, TENS units, or cognitive behavioral therapy for pain, and, in some states, medical marijuana, which doesn't suppress testosterone the way opioids do. If opioids are absolutely necessary and cannot be discontinued, your doctor can monitor your testosterone levels with blood tests and potentially prescribe testosterone replacement therapy to counteract the suppression. However, addressing the root cause by reducing or eliminating opioids is always preferable. One patient had been on oxycodone 20 milligrams twice daily for chronic back pain for 4 years. His testosterone had dropped to 180 nanograms per deciliter, less than half the normal range. He had zero libido and couldn't achieve erections at all. After working with a pain management specialist to transition to a combination of physical therapy, NSAIDs, and periodic nerve blocks, he was able to reduce and eventually eliminate the opioid over 6 months. His testosterone recovered to over 420 nanograms per deciliter, and his erectile function and libido returned substantially. He said, "Getting off opioids was hard, but getting my sex life back was worth every bit of effort." Chronic pain management doesn't have to destroy your hormones and your sex life. There are better, safer alternatives that preserve your testosterone and sexual function. Medication number 4. Antihistamines, including over-the-counter allergy medications. The fourth medication class is antihistamines, and this one surprises most men because many are available over-the-counter without prescription. These include diphenhydramine, which is Benadryl, loratadine, which is Claritin, cetirizine, which is Zyrtec, and cimetidine, which is Tagamet, an H2 blocker used for heartburn. Cimetidine is particularly problematic It has anti-androgen properties, meaning it blocks testosterone receptors and directly reduces testosterone's effects on tissues throughout your body, leading to reduced libido and erectile dysfunction. Here are the mechanisms. Mechanism 1. Sedation that reduces libido. First-generation antihistamines like Benadryl cross the blood-brain barrier and cause significant central nervous system depression. This sedation directly reduces sexual interest and arousal. Mechanism 2. Anticholinergic effects. Many antihistamines block acetylcholine receptors. Acetylcholine is involved in the parasympathetic nervous system pathways that control erections. Blocking these receptors interferes with the signals necessary for achieving and maintaining erections. Mechanism 3. Anti-androgenic effects specific to cimetidine. Cimetidine blocks androgen receptors, preventing testosterone from binding and exerting its effects. This can cause gynecomastia, breast tissue development in men, as well as erectile dysfunction and loss of libido. What you can do about it? For seasonal allergies, consider non-sedating, newer generation antihistamines like fexofenadine, which is Allegra. These don't cross the blood-brain barrier as readily and have minimal sedating and anticholinergic effects. Even better, consider nasal corticosteroid sprays like fluticasone, which is Flonase, mometasone, which is Nasonex, or budesonide, which is Rhinocort. These work locally in your nasal passages and have minimal systemic effects, making them very unlikely to cause sexual problems. For acid reflux and heartburn, if you're taking cimetidine specifically, talk to your doctor about switching to proton pump inhibitors like omeprazole, which is Prilosec, esomeprazole, which is Nexium, or pantoprazole, which is Protonix. Or consider famotidine, which is Pepcid, another H2 blocker that doesn't have the anti-androgenic effects of cimetidine. Avoid chronic daily use of sedating antihistamines like Benadryl for non-essential purposes like sleep. There are better sleep aids with fewer sexual side effects, including melatonin or prescription options like trazodone at low doses. One patient was taking Benadryl 50 milligrams nightly as a sleep aid and Claritin 10 milligrams daily for allergies. After switching to melatonin 3 milligrams for sleep and Flonase nasal spray for allergies, he noticed improved morning erections and better daytime energy within 2 weeks. The cumulative anticholinergic burden from 2 antihistamines had been suppressing his sexual function without him realizing it. Even over-the-counter medications can have significant sexual impacts, especially when used chronically or in combination. Medication number 5. Hair loss medications, finasteride and dutasteride. The 5th medication is finasteride, sold as Propecia for hair loss or Proscar for enlarged prostate, and dutasteride, sold as Avodart for enlarged prostate. These medications work by inhibiting 5-alpha reductase, the enzyme that converts testosterone into dihydrotestosterone, or DHT. While reducing DHT helps with hair loss and prostate enlargement, it also affects sexual function. Research shows these drugs suppress libido in about 10% of men. Here are the mechanisms. Mechanism 1. Reduced DHT levels. DHT is a more potent androgen than testosterone, about 5 to 10 times stronger. It's critical for male sexual development and function. By reducing DHT by 70% or more, finasteride alters the androgenic environment in your body, leading to reduced libido and erectile dysfunction in susceptible men. Mechanism 2. Neurosteroid disruption. Finasteride also affects the production of neurosteroids in the brain, compounds derived from steroids that influence mood, anxiety, and sexual function. Disrupting neurosteroid balance may contribute to both sexual and psychological side effects. Mechanism 3. Altered androgen receptor sensitivity. Some research suggests that chronic 5-alpha reductase inhibition may alter androgen receptor density or sensitivity in tissues, making them less responsive to testosterone, even when testosterone levels are normal. The sexual side effects include reduced libido and sexual interest, erectile dysfunction or reduced erectile quality, reduced ejaculate volume often by 20% to 30%, gynecomastia or breast tissue development in some men, and in rare cases, persistent sexual dysfunction even after stopping the medication, similar to post-SSRI sexual dysfunction. Post-finasteride syndrome, first described in 2011, involves persistent sexual, neurological, and physical symptoms that continue after discontinuing the medication. While the exact mechanism isn't fully understood, it appears to involve long-lasting changes in androgen receptor sensitivity or neurosteroid metabolism. This condition remains controversial but is increasingly recognized as a real phenomenon affecting a small percentage of finasteride users. What you can do about it. If you're taking finasteride or dutasteride for hair loss, have an honest conversation with yourself and your doctor about whether hair preservation is worth the risk of sexual dysfunction. For many men, the answer is no. Consider topical minoxidil instead, which is Rogaine. It doesn't affect hormones systemically and works by increasing blood flow to hair follicles locally on your scalp. While it's not as effective as finasteride for preventing hair loss, it has zero sexual side effects. If you're taking finasteride or dutasteride for enlarged prostate and urinary symptoms, ask about alternative treatments. Alpha blockers like tamsulosin, which is Flomax, alfuzosin, which is Uroxetrol, or silodosin, which is Rapaflo, treat urinary symptoms by relaxing the smooth muscle in your prostate and bladder neck without affecting hormones. Note that alpha blockers have their own side effect of retrograde ejaculation in some men, where semen goes into the bladder instead of out through the penis. However, this doesn't affect erection quality or libido the way finasteride does. Minimally invasive procedures like Urolist, which uses small implants to hold prostate tissue out of the way, or Resum, which uses steam to shrink prostate tissue, can treat enlarged prostate mechanically without any medication or hormonal effects. One patient stopped finasteride after 3 years of progressive sexual decline. He'd been taking it for male pattern baldness. Within 8 weeks of stopping, his libido returned substantially, and his erectile function improved noticeably, though not completely back to baseline. He chose to accept gradual hair thinning, rather than continue sacrificing his sex life. He said, "Having hair doesn't matter if I can't enjoy intimacy with my wife. Hair loss treatments and prostate medications aren't worth losing your sexual function. There are alternatives that preserve your quality of life." Here's exactly what to do if you suspect your medications are affecting your sex life. Step 1. Create a detailed medication timeline. Write down every prescription medication, over-the-counter drug, and supplement you take regularly. Include dosages, when you started each one, and any dosage changes. Step 2. Correlate with sexual function timeline. Note when your sexual problems began. Did they coincide with starting a new medication or increasing a dosage? Did they worsen when you added another medication? This temporal correlation is critical diagnostic information. Step 3. Schedule a focused medication review. Make an appointment specifically to discuss sexual side effects. Don't bring it up casually at the end of a visit. Make it the primary purpose of the appointment so your doctor takes it seriously and dedicates adequate time. Be direct and specific. Say, "I'm experiencing erectile dysfunction and reduced libido. I want to review all my medications to identify which might be contributing and discuss alternatives." Step 4. Never stop medications independently. Some medications, particularly antidepressants, blood pressure medications, and pain medications, require gradual tapering under medical supervision. Stopping suddenly can be dangerous, causing rebound effects, withdrawal symptoms, or medical emergencies. Step 5. Ask about alternatives systematically. For almost every medication with sexual side effects, there are alternatives with lower sexual impact. Your doctor can usually find an equally effective substitute. Be persistent. If your doctor dismisses your concerns, consider seeking a second opinion. Step 6. Consider dosage optimization. Sometimes, lowering the dose reduces side effects while maintaining therapeutic benefit. Or changing the timing, taking a medication at night instead of morning, can reduce sexual impact. Step 7. Allow adequate time for assessment. After switching medications, allow several weeks to several months for your body to adjust and for sexual function to recover. Don't change multiple medications simultaneously, or you won't know which change caused improvement. Step 8. Consider augmentation strategies. If you must continue a medication causing sexual problems, ask about adding medications to counteract the sexual effects. Bupropion can counteract SSRI sexual dysfunction. Phosphodiesterase 5 inhibitors like sildenafil can improve erections despite medications. Testosterone replacement can counteract opioid-induced hypogonadism. One patient systematically reviewed all 7 of his medications with his doctor over 3 visits. They identified 3 that commonly cause sexual problems: a thiazide diuretic, an SSRI, and cimetidine for heartburn. After switching the diuretic to an ACE inhibitor, switching the SSRI to bupropion, and changing cimetidine to omeprazole, his erectile function and libido improved dramatically over 3 months. He said, "It took effort and patience, but getting my sex life back was worth every appointment." A systematic, methodical approach works when you're committed to finding solutions. Gentlemen, here's what you need to understand. Approximately 25% of all erectile dysfunction is caused by medications. That's 1 in 4 men. The 5 most common culprits are antidepressants, especially SSRIs, affecting 30% to 73% of users through multiple serotonin-mediated mechanisms, blood pressure medications, especially thiazides and beta blockers, through reduced blood flow and sympathetic nervous system interference, opioid pain medications, causing testosterone suppression of 50% or more through hypothalamic pituitary disruption, antihistamines, including over-the-counter allergy medications, through sedation and anticholinergic effects, and hair loss medications like finasteride and dutasteride, through DHT reduction and neurosteroid disruption. These medications affect sexual function through complex biological mechanisms involving neurotransmitters, hormones, blood flow, and receptor systems. Understanding these mechanisms helps you have informed conversations with your doctor about alternatives. The critical message is this: don't suffer in silence. Medication-induced sexual dysfunction is often completely reversible by switching to alternative medications with lower sexual side effect profiles, adjusting dosages, changing timing, or adding augmentation strategies. Never stop taking prescribed medications without consulting your doctor, but absolutely discuss sexual side effects openly and honestly. Your doctor can almost always find solutions that maintain your health while protecting your sex life. If your doctor dismisses your concerns or says nothing can be done, that's a red flag. Seek a second opinion. Your sex life matters. It's a legitimate health concern that significantly impacts quality of life, relationships, and overall well-being. You deserve medical care that addresses your whole person, not just individual symptoms. Starting this week, make your complete medication list with timeline. Schedule a focused medication review appointment and be direct about your concerns. Advocate for yourself. This is your health and your life. If this video helped you, hit that like button right now. Comment below and tell me, are you taking any of these 5 medications? What has your experience been? And subscribe for more honest, comprehensive, science-backed health guidance for men over 50. I'm Dr. Mika Hayashi. Medication-induced erectile dysfunction is fixable through informed decision-making and systematic problem-solving. You don't have to choose between your health and your sex life. There are solutions. Talk to your doctor. Protect both your health and your sexual function. You deserve comprehensive care that preserves your quality of life.